Good day, dear colleagues. I'm happy to meet you here today in the webinars that are organized by Crystal Vision Clinics, eye clinics by Professor Igor Aznaran. Every week we have webinars for different topics on ophthalmology, ophthalma surgery, pediatric and adult ophthalmology. So today we will talk about tactics in peripheral retinal dystrophies, a topic that is important for every doctor who is working in ophthalmology practice, because by uh, finding these dystrophies and having a right tactic according to them, we can prevent many dangerous ophthalmological problems as retina detachment and so on. So today, Dr. Victoria Balasanyan will tell us about how we need to manage retinal dystrophies, what is the tactic, and how we need to go through this uh, this disease, and what is a new approach after that. So please, Dr. Victoria.
Good morning, dear colleagues. I'm glad to welcome you to our webinar. It's great that we have established a tradition of meeting for a webinar every week. And today I would like us to recall the types of peripheral retinal dystrophies and also discuss modern approaches to managing and treating these dystrophies. Peripheral retinal dystrophy is a pathological process occurring at the periphery of the fundus, involving the retina, chorioid, and vitreous body. There are many options for classifying peripheral retinal dystrophy: by localization, depth of the retinal damage, pathomorphology, prognosis, and so on. This disease usually progresses asymptomatically for a long time. Often the discovery of this pathology occurs incidentally. That is, when a patient consults an ophthalmologist for the other complaints. So physical overloads, contact sports such as boxing, stress, and other provoking factors, for example, a powerful exertion during childbirth, can lead to the further progression of the disease and to the most serious complications, such as retinal detachment. One of the main pathogenetic factors in peripheral retinal dystrophy is the alteration of hemodynamics in the eyeball. There are suggestions about the possible disruption of metabolism and the structure of cellular membranes against the backdrop of insufficient blood circulation in the peripheral region of the retina. Such changes are assessed as circulatory hypoxia and ischemia. Other causes that create conditions for the development of the peripheral retinal dystrophy include hereditary factors, vascular somatic diseases, hypertension, diabetes mellitus, etc. Previous head injuries and eye trauma, various intoxications and infections diseases, and immunological disorders. Peripheral retinal dystrophy in the early stages can only be detected by examining the fundus in conditions of mydriasis. In some cases, peripheral retinal dystrophy may have symptoms that few people may pay attention to, like floating spots, lines, flashes, or black smoke. That's why regular fundus examination is very important for all patients. The commonly used classifications of peripheral retinal degenerations based upon depth of retinal change observed on optical coherence tomography. Chorioretinal degenerations, paving stone degeneration, and peripheral retinal drusen. Vitreoretinal degenerations, that is degeneration, snail track degeneration, retinal tuft, and peripheral retinal bricks. Intraretinal degenerations, senile retinoschisis, white without pressure, white with pressure, dark without pressure, peripheral cystoid degeneration, snowflake degeneration, and pearl degeneration. Let's begin with chorioretinal dystrophies without vitreous involvement. One of the most common types of dystrophy is retinal drusen, commonly found in patients 40 years or older. They appear as yellowish-white deposits localized in brush membrane and the retinal pigment epithelium of the eye. Drusen vary in shape and size, but they are usually round. They are characterized by a glistening crystalline consistency. Equatorial drusen refer to those located on the mid-periphery of the fundus. These drusen more frequently lead to hyperpigment clusters, drusen surrounded by a ring of pigment. Drusen appear white when they become calcified, so the progression is asymptomatic. Capillary stone degeneration, also known as paving stone degeneration or chorioretinal atrophy, refers to round peripheral zones of atrophy in the retinal pigment epithelium and choriocapillaris. It's usually located between ora and equator with size of 1 to several disc diameters, more common in inferior nasal and temporal quadrants, presenting for 28% of patients. It doesn't depend on gender and is becoming more common with age. The size of these atrophic areas ranges from 0.1 millimeter to several disc diameters. Pigment often accumulates at the edges or in the center of these lesions. Microcystic degeneration is characterized by the appearance of small cystic formations in the peripheral areas of the retina. This type of peripheral retinal lesion is most often found in premature infants and elderly over 70 years old. Over time, microcysts can merge into larger formations, and there is a possibility of spontaneous rupture. There are two types of cysts. Typical occurs in all adults, may be complicated by the fusion of cysts and the development of cavities in the outer plexiform layer and flat senile retinoschisis. So reticular occurs in 80% of adults, may be complicated by bullous retinoschisis with cavities in the retinal nerve fiber layer. This form almost always occurs after typical peripheral cystic degeneration and tends to develop along the retinal vessels. Retinoschisis or retinal splitting can be either congenital or acquired. Retinoschisis means splitting of the eye's retina into two layers. There are two forms of this disorder. The most common is an acquired form that affects both men and women. It usually occurs in middle age, although it can occur earlier, and it's sometimes known as senile retinoschisis. The other form is present at birth, congenital, and affects mostly boys and young men. It's known as juvenile X-linked retinoschisis. This disorder is characterized by a slow, progressive loss of parts of the fields of vision corresponding to the areas of the retina that have become split. Either form may be associated with the development of sac-like blisters, cysts in the retina. Retinoschisis may involve a posterior pole and be the cause of retinal detachment in most cases. Retinoschisis should be treated with argon laser photocoagulation when patients are symptomatic, or there is progressive retinal detachment threatening the macula. Different sources give different data on the prevalence of white without pressure degeneration. Some authors report that this degeneration is found in up to 30% of normal eyes and is usually bilateral. Other authors claim that white without pressure is most frequently diagnosed in young patients. And there is a definite correlation with the axial length. So there were no cases of degeneration in eyes with an axial length of 21 millimeter, and 45% of cases in eyes with an axial length of more than 33 millimeter. According to some authors, the change of retina color from orange-red to white or gray-white are due to the vitreous traction, whereas other authors explain the retina whitening by increased density of collagen at the inner retinal surface. Thus, it was found that white without pressure is not associated with vitreoretinal traction and an increased risk of retinal detachment. Therefore, this degeneration is not considered an indication for preventive laser photocoagulation. The patient should be examined regularly every 1-2 years, informed of the symptoms of retinal rupture or detachment, and asked to have a retinal examination when these symptoms appear. Snowflake degeneration looks like small yellow dots in the peripheral retina, appear white due to light reflection, usually deposits in the retina from the ora serrata to equator. Multiple white deposits look like snowflakes, and they can be located in a white band in more than one quadrant of the retina, most often in the superatemporal quadrant. Snowflake degeneration can be combined with other degenerations, for example, with retinoschisis, as on these scans. Snowflake degeneration often can be cause of retinal rupture, retinal detachment, so it should be immediately treated with argon laser photocoagulation. Pearl degeneration is a rare congenital pathology of the peripheral retina that may look like white balls resembling retinal drusen. Rare pearls appear as milk-white glistening spheroids located at the ora serrata or pars plana. There is usually a single isolated pearl, or less frequently multiple pearls that are bilateral and symmetrical. Pearls degeneration are benign and do not require preventive laser treatment. Next, we will discuss those type of peripheral retinal dystrophies in which the vitreous body is also involved in the pathological process. These are peripheral vitreoretinal chorioretinal dystrophies. Perhaps these dystrophies should be approached with particular caution, as they are more associated with the risk of retinal detachment. Lattice degeneration is a common peripheral retinal degeneration that is characterized by retinal thinning with fibrosis and vitreous liquefaction over the lesion, spindle-shaped areas of retinal thinning with or without pigmentation, arborizing white lines, frost-like areas, commonly located between the equator and the posterior border of the vitreous base. On fundoscopy, we can see oval or linear pattern of lesions, maybe one lesion or multiple, may have yellow deposits, pigment, atrophic holes, or retinal tears. There are two types of lattice degeneration: typical, well-outlined thinning with white crossing lines, atypical, found adjacent to vessels in radial pattern. Lattice degeneration is a common condition that can be found in 6-8% of the general population. Risk for retinal detachment and rhegmatogenous retinal detachment due to vitreous traction is quite high, from 14 to 35% cases. That's why preventive laser treatment is most commonly recommended, especially in patients with vitreous traction and retinal tears associated with flash cell fluids. For example, here you can see the lattice degeneration with retinal tears. So, of course, in a case like this, we must do laser photocoagulation. Another very important vitreoretinal degeneration is snail track degeneration. It looks like groups of glistening white dots, which have been compared to frost granules or salt. Often it can be early stage of lattice degeneration. Snail track found in 10% of general population, more commonly in myopic eyes, 40%. Often localized in superatemporal and supranasal quadrants. On fundoscopy, we can see retinal thinning with vitreous liquefaction above the lesion associated with vitreoretinal tractions. Histologically, this lesion consists of degeneration of the neural elements of retina, leading to an atrophy of the tissues with lipid deposits in the internal retinal layers. OCT findings show irregular retinal surface, vitreous distraction, vitreoretinal adhesions with traction at the margins. Snail track may lead to retinal tears in up to 55% of patients. Retinal holes, however, in cases like this, when there isn't any traction, we can recommend follow-up and make a decision about laser treatment some period of evaluation. But sometimes on OCT, we can diagnose non-typical snail track degeneration with aggressive tractions. In such cases, laser photocoagulation is highly recommended. Retinal tufts. This is a type of vitreoretinal dystrophy with area of retinal degeneration caused by attachment to and pulling of the vitreous. There are different types of tufts: cystic, non-cystic, and zonular traction tufts. Retinal non-cystic tufts found in 72% of adults. Cystic present in up to 5% of adults. Zonular traction tufts are present in up to 15% of adults. Vitreous traction can lead to retinal tear and retinal detachment, but preventive laser treatment often not recommended. However, if during the OCT examination you diagnose tractions like this, you should make an important decision about preventive laser treatment. The term retinal tear refers to any defect that affects the full thickness of the neural retina. The clinical significance of retinal tears lies in the fact that fluid from the vitreous cavity can seep into the space between the sensory retina and the retinal pigment epithelium, thereby causing rhegmatogenous retinal detachment. Some tears are caused by atrophy of the inner layers of the retina. Others occur due to vitreoretinal traction. Retinal tears can be classified as following: valve or hook-shaped tear, giant tear, tear with a flap, detachment, whole tear. A valve tear occurs when a part of the retina is pulled forward due to vitreoretinal traction, often during posterior vitreous detachment or trauma. Valve tears should be treated with preferential laser treatment. In cases where the traction forces are sufficient to completely detach a section of the retina from the adjacent retinal surface, a tear with a flap occurs. A tear with a flap occurs should be treated by preventive laser treatment too. Well, dear colleagues, we have discussed the topic of peripheral retinal dystrophies. I'm sure that it's very important for our daily practice to refresh our knowledges in this area of ophthalmology, as peripheral retinal dystrophy are a condition we regularly encounter in our exam. I would be very happy to answer your question. Thank you very much.